Namaste and a warm welcome to all of you joining us today for this webinar. As usual, it is a great pleasure and zeal with zeal that I, Dr. Pallavi Chaugule, Associate Professor and HOD, MRIS Gandhinagar, currently working as Joint Secretary of Rog Nidan Vikruti Vigyan PG Association, welcome you all to our 30th webinar on sleep disorders and management. This webinar is approved by Maharashtra Council of Indian Medicine, Mumbai. It is pleasure that you all have joined us today on this virtual platform to open up the intricacies of sleep disorders. Sleep is a fundamental aspect of our lives, yet for many it remains elusive. Whether it's struggling to fall asleep, stay asleep, or experiencing disruptive patterns, sleep disorders can significantly impact our health and quality of life. Sleep disorders are a group of conditions that affect the quality, timing, and duration of sleep. They encompass a wide range of issues, from difficulty falling asleep and staying asleep to experiencing abnormal behaviors during sleep. These disorders can have significant impacts on overall health, cognitive function, mood, and daily functioning. So, understanding sleep disorder involves exploring their underlying causes, which can range from physiological factors such as genetics and medical conditions to environmental factors like stress, lifestyle choices, and sleep hygiene practices. In Ayurveda also, Nidra is considered as one of the Traya Upastambha. It is very essential to have sound and proper sleep. Various psychosomatic disorders have mentioned sleep irregular patterns as a lakshan.
Hello.
So, we are privileged. Hello, am I audible? Yes, sir.
Yes, ma'am.
Yes, ma'am.
Okay, sir. So, we are privileged today to have a renowned practitioner and expert, Dr. Sushant Meshram, sir, as our speaker. Sir is a very senior consultant. Our chairperson for today is Dr. Sachin Deva, sir, Professor, Rog Nidan Vikruti Vigyan, Parul Institute of Ayurveda and Research, Vadodara. Sachin, sir, has an experience of more than 11 years of UG and teaching experience. And sir has also covered many research projects along with in association with the Gujarat University and Parul University and also Government of Gujarat. As we are about to begin our today's knowledge quest, I request Dr. Satyendra Kumar Singh, sir, working as Associate Professor, Rog Nidan at PDEA College of Ayurveda and Research Center, Nigdi, Pune, to introduce our association to all our participants. Over to you, Satyendra, sir.
Yes, thank you, madam. Thank you, Pallavi, madam, for giving me this opportunity to introduce our organization. About RVPGA. Our organization RVPGA was formed in the year 2016 under dynamic leadership of Dr. Subhas Wage, sir, with the aim to give the legal status of pathologist and radiodiagnostic to the PGs of Rog Nidana. Our organization is duly registered under Societies Act of 1860 at Charity Commissioner Office, Nagpur. Now, who can be our members? Postgraduate students, teacher of Rog Nidan and Vikruti Vigyan and Chaya Vikiran Vigyan can become our members. Our is the only organization which is fighting for the lawful rights of Rog Nidan and Vikruti Vigyan of PGs. Even the NCISM had also directed State of Maharashtra to consider RVPGA as stakeholder in the constitution of pathology regulatory body of the state. RVPGA is pursuing this matter with the state and central government also. Now only the RVPGA is constantly pursuing the implementation of NCISM salary structure in all private Ayurvedic colleges across the nation. All the communication and details are uploaded on our website, that is www.rvpganagpur.com. What are the activities we are doing till now? The first one is regularly we are conducting online webinars and offline seminars, both on national and international platform. So far, we have conducted 30 national webinars on different diagnostic topics at a national conference on X-ray diagnostic at Nagpur. Another one is hands-on training program for PGs at our partner NABL accredited pathology laboratory at Mumbai, Nagpur, and Pune. We have also planned a microbiological hands-on training program for our PGs on 9th March 2024 at Nagpur. We are publishing a research paper of Nidan Nidan students and faculties of our peer-reviewed journal, that is International Journal of Diagnostic and Research, IJDR. And till now, 2 issues have been published till now. And those who are interested can also visit our website, that is www.ijdrindia.com. I am happy to announce that our journal is enlisted in 80 databases. We are planning book chapters through our edited book volume series, which is an international publication called RIPI and is duly registered in Government of India's ISBN portal. Those who want to contribute book chapter can visit RIPR website, that is www.rvpgaiip.com. We have published All India Rognidan PG thesis book consisting of all the Rognidan PG title from 1985 to 2023 for the easy reference for our PGs and faculties. This year we have started 2 courses, DAPT, that is Diploma in Advanced Pathology Training, and DXDT, that is Diploma in X-ray Diagnosis and Techniques. Both the courses are affiliated to reputed RST Nagpur University. We request aspirants to take benefit of it. We have also a YouTube channel and a Facebook page where you can see our educational activities past and life. So this is about RVPGA. And I request Pallavi madam, may I take a leave because we have LIC committee in our
Yes,
college.
sir. Yes, sir. Yes, sir. Thank you. Thank you for doing the
Thank you,
honors.
ma'am.
Thank you for introducing our association. Now
Thank you,
it
ma'am.
is time. Now it is time to introduce our today's speaker. We are really privileged to have Dr. Sushant Mishram sir here. He has a huge biodata and credits to his account. Starting from, he completed his MBBS in 1993 from Government Medical College, Nagpur. He continued his studies, pursued his dreams by taking MD in chest medicine in 1998 from Government Medical College, Nagpur. Further, he has done fellowship training program in sleep medicine 2008 from Johns Hopkins Medical University, Baltimore, USA. Sir has also been an instructor at Advanced Cardiac Life Support American Heart Association in 2008. Apart from this, Sir has numerous fellowships and memberships to his credit. He is a fellow of American College of Chest Physician, USA. He is a member of American Academy of Sleep Medicine, USA. Sir is a fellow National College of Chest Physician, India. Sir is also a member of Indian Association of Sleep Disorders, India. He has also fellowship from Indian Chest Society, India, and Indian Medical Association. Sir is currently professor and head of Department of Pulmonary Critical Care and Sleep Medicine, Government Medical College, Nagpur. Sir is in teaching field for more than 19 years, and is an associate professor for more than 11 years. Apart from this, Sir has many honors of being an organizing chairman, being founder president, or he has also the credit of being the Research Advisory Council member for the National Institute of Miners Health, Ministry of Mines, Government of India. So this is just the tip of iceberg we can see of his biodata. Sir has a huge ocean of knowledge and expertise, and today we are all going to get benefited by his knowledge. Sir, requesting you to start your session. Hello? Sushant sir?
Yeah.
Dr. Sushant
Hear
sir?
me, yeah. Can you hear me?
Yes, sir. Yes,
Yeah.
sir. Yes, sir. You can
At the
start your session.
Yeah. At the outset, I would like to thank the organization Rog Nidan Vikruti Vigyan PG Association and its office bearer, Dr. Subhash Wage sir, Avinash Ladke sir, Santosh Chavan sir, Dr. Vaishali Ganorkar, and the webinar coordinator, the one who has introduced myself, Dr. Pallavi Chowgule. So thank you, Dr. Pallavi, for introducing me with such a nice words. Probably I may not deserve those words. Now, coming back to my talk, today we are going to talk on sleep. Basically, the topic which has been given to me by Dr. Vagesar was sleep disorder diagnosis and management. So before going to discuss regarding the sleep disorders and its management, we need to have some brief overview of sleep. What is sleep and how are the various sleep disorders being diagnosed and managed? Now, so this is my institute where I worked as a fellow in sleep medicine at Johns Hopkins Medical University. And the picture what you are observing is my guide there, Dr. Nancy Calaf, who happens to be a president of American Academy of Sleep Medicine. My talk is outlined as present that we will just have a brief discussion on normal sleep and why do we sleep, what are the magnitudes of sleep disorders, sleep deprivation, public health, relationship between the sleep and other medical specialties, and we'll have some few case discussion based upon the availability of time. Because sleep itself is a huge topic, I don't feel that it will be covered within 1 hour, but I would like to cover as much as possible. Now, if you go to the Indian text, as Dr. Pallavi has mentioned in her introduction, that even in Ayurveda, there is a lot of mention in the sleep, and sleep has given importance. It is a third pillar of your health. So in our ancient text also, you can see that sleep has been described as a part of consciousness in Vedas and Upanishads. You know, they describe Jagrata Avastha as awake, Swapna Avastha, dream, obviously, Sushpati as a dreamless sleep, Shushpati is a dreamless sleep, and Turiya is a spiritual state of consciousness. In Quran also, it has been mentioned as a wafat. They call sleep as a temporary death and death as a real death, obviously. In Christianity and Jewish philosophy, there is a mention of a sleep, that sleep is a gift from God, what the Bible says. Hard labor can induce the deepest form of sleep. Worry about material possessions results in sleeplessness. So at that time, I meant to say almost 2000 years ago, 2500 years ago, it has been described that most of the features of this, you can say insomnia and related common cause for this has been mentioned in the various texts of various religions. Now, in Buddhism also, they have mentioned that sleep is a biological function. And if suppose the person who is remaining all night awake will definitely have negative impact on their lives. So this has been mentioned in the Buddhist text also. And this statement is still relevant in our era. So what Buddha has observed that our behavior while awake can sometimes have effect on during sleep. So whatever the type of behavior we are having during daytime, it may cause some sort of the negative impact on your sleep pattern, resulting into the insomnia or restless sleep. And another thing, what he has mentioned, that the person who is having a loving disposition for sleep, so the person will have a happy sleep, he will wake happily and he will be having no bad dreams, so he'll be perfectly healthy. So sleep is playing immense role in your quality of life or healthy life. Now, what is sleep? Modern science describes sleep as is a natural, periodically recurring state of inactivity, readily reversible, characterized by loss of consciousness and reduced responsiveness to the external stimuli. This is what the physiological definition of sleep. Why do you sleep? This is a billion-dollar question. Answer is for restoration and recovery of the physiological function. Sleep is very essential. For tissue repair, sleep is essential. For brain anabolism, example, synthesis of glucose. So you can say the storage of energy or sense of energy, sleep is very important. Another important function which is performed during sleep is the consolidation of memory. energy conservation, and breath grown development. If suppose any person who is deprived of the sleep or the sleep is having poor quality, these are two concepts you can say: sleep deprivation and poor quality sleep. So if it is there, then that individual is definitely going to have hampered sleep function, and he may develop some sort of the complaints or symptoms related to the loss of sleep. We must salute these scientists, those who have discovered the uh, sleep patterns and EEG. He was the scientist Hans Berger who described the EEG pattern, because of which we are able to what I can say monitor or study the sleep. Now these were the two scientists, physiologists. There is a guy, I mean, mentor and student, Nathnal and Eugene. Eugene, while studying the sleep during night hours, found that though the cat was sleeping, he was like, doing experiment on the cat was sleeping, but the cat's eyeball was rolling out during the sleep. So he discovered the REM pattern of the sleep, which is very important for the memory consolidation and brain growth. Now, I'll not go into the detail of it, just to mention that how we are going to record the activity of brain during sleep. Because during sleep, the brain activity is obviously going to be different, and during daytime, brain activity going to be different, and abnormal functioning, the brain activity going to be different. Abnormal functioning means what? Like epilepsy patient. On the basis of EEG recording, we can diagnose the epilepsy. On the basis of EEG recording, we can just make out whether the person is sleeping or is awake, because different sort of the wave patterns are present during sleep and wakefulness. Now, these are the recordings, how the recordings have been done. Now, here you can see these are what the pyramidal cell of the neuron, I mean brain, and each neuron or each cell, if it get activities, will produce some electrical activity. And if suppose these electrical activities are asynchronized, means not synchronized. For example, this is one. Can you see it? 1, 2, 3, 4, 5, 6. So these are the recording of the 6 neurons. They are not synchronized. So summation of this not synchronized electrical activity will result into what? This sort of the EEG pattern, which is having low amplitude. If suppose same firing of the electron, activation of the activity of neurons are synchronized, then the electrical activity would be having large amplitude. This is the difference between synchronized activity and unsynchronized activity. Why I'm telling all these things? Because during daytime, the most of the activities, most of the neurons are firing at different level. And during night time, the most of the brain neurons are having synchronized activity. Fine. That's why during night, the deep sleep, you will have the larger type of, large amplitude EEG recording. Now, these are the various rhythms which are present in the EEG recording. What we call, most of you might be knowing it. We call as alpha, theta, and delta rhythms. These are usually found in the sleep, and beta rhythm is during alertness. So here you can see, keep in mind that alpha rhythm is waveform which is having frequency of 8 to 13, theta is 4 to 7, and delta is having frequency of less than 4. Now, I'll skip this part of the slide because of the constraint of time. This is what the neurobiology of sleep. I will skip all these things. Okay. Now, with this simple cartoon, you can see how the sleep is functioning. So this is the diagram which is showing hypothalamic and brainstem sleep wave regulation system. We need to just remember that there are sleep promoting neurons, what we call VLPO, that is ventrolateral preoptic area, this neuron group of neurons which are located in the hypothalamus. So if suppose these neurons are activated, the sleep is promoted, and wake promoting neuron are hypocretin or orexin neurons which are located in the lateral hypothalamus. Fine. So if suppose they are stimulated, the person will be awake. You might have heard of a disease which what we call narcolepsy. Okay. Narcolepsy means a person who is having continuously sleeping throughout the daytime, hardly wakes up for his routine activity, and this is due to the lack of hypocretin in his brain or her brain. So hypocretin is very important for wake promotion. or to remain alert. And this VLP or hypocretin. This hypocretin is what wake promoting and VLP is a sleep promoting. These two group of neurons have coordination with the ascending arousal system, which is present in the brainstem. It's very simplified way of this sleep-wake regulation system, what I told, but it's not that simple. Just to remember is what VLPO, that is sleep promoting, and hypocretin, that is what alert, alert keeping neurons. Now, recently recently in 2017, this three scientists, Jeffrey, Michael, and Michelle, got a Nobel Prize for their discovery regarding the mechanism of or genetic mechanism of circadian rhythm. Circadian rhythm, I mean to say that our body is works in the rhythmic phase. It is having direct correlation with the sleep-wake cycle, which is associated with the dark and light cycle. You know, during dark period we are sleeping, with light period we are remaining awake. So entire your body system, right from your cellular level, subcellular level also, every function is being coordinated with a light or dark light cycle. I'm audible to all, no? Hello?
Yes, sir,
Hello?
you're audible, sir. Yes, sir, you're audible, sir.
Because what happened in this online program,
Webinar, sir.
yeah, we do not get feedback whether means,
Yes, sir.
yeah, fine. So
Yes, sir.
yeah, fine. Then this is what the circadian rhythm. You can see here at 6 o'clock. After 6 o'clock, there is a sharp rise in the blood pressure, and this is a hormone melatonin which stops secreting. Then we go for the bowel movement. There's increased level of testosterone. There's a noon period. Then in evening period, you can find it that there is a high blood pressure, high body temperature, and melatonin secret start again at 9 o'clock. The moment there is a sunset, there is a starting or secretion starts of the melatonin after sunset and reaches to the peak of around 9 to 10. So that's that particular time, you know. We do get some sleep drive, intense sleep drive to sleep during 9 to 10 p.m. If suppose we are going to miss this drive, then probably the person may not be able to sleep till 2 o'clock or by 1 a.m. At that time, another second drive comes. So if you are going to miss that drive also, the person is not able to sleep. Fine. So we need to respect the drive of melatonin, sleep drive, intense sleep drive. I'll skip all these details. Now coming to the state of beings. For a common man, lay person, we know only two phases of our life. That is what? Wakefulness and sleep. But as a sleep physician, we describe the life into three phases. That is wakefulness, sleep, which is what we call NREM sleep, and another phase of your life is REM sleep. In NREM sleep and REM sleep, what is common is that the person is lying down and appears to be slept. Fine. But physiologically, just like sleeping phase, physiologically distinct from the wakefulness. In same manner, physiologically, non-REM sleep is very much distinct from the REM sleep. So we'll have a discussion in subsequent slides. So normal sleep pattern means when we go to the bed, and after going to the bed, at least between 20 to 30 minutes, one should get initiation of sleep. If suppose is delayed by more than 30 minutes, then that person is usually suffering from insomnia. Fine. Then what is normal sleep architecture? The sleep architecture has to be maintained in this proportion, what has been seen on your screen, that normally we are spending 75% of the time in non-REM sleep, which again consists of three subsequent stages, like 1, 2, 3, and then REM sleep. 20% of your total time should be REM sleep. So if you are spending 1, 2, 3, that is 5% in the stage 1, 50% in stage 2, and 25% in stage 3, 15 to 20% in stage 3, and remaining 20% REM sleep. So in each cycle, the cycle lasts for 90 minutes. Then we say that you are having quality sleep. Very important concept we need to remember here, that duration of the sleep is not only important, but also equally important, or more important, is the quality of sleep. Quality of sleep means what? One need to spend at least 5% of time of the sleep in stage 1 of the sleep, stage 2, 50% time, 15 to 20% time in stage 3, and 25% of the total sleep time should be spent in the REM sleep, that is rapid eye movement sleep. REM means rapid eye movement. NREM means non-rapid eye movement. Okay. So each cycle, that is REM, non-REM, REM, non-REM, this completes the one cycle. So this one cycle lasts for the 90 minutes. If suppose any individual who is sleeping for 6 hours, for example, so he will have 4 such cycles. Fine. 4 such cycle, that is 1.5 hours each cycle. 90 minutes, 1.5 hours. Got it? Now this is how this sleep cycle stages are. Stage 1, then stage 2, stage 3, and stage REM. Fine. So here you can see that in stage 1, the sleep is initiated, we feel drowsy, okay, and then deep sleep starts. The stage 2, what we call is a we also call it the stage where the data processing is done by brain. So it's a more stable sleep. Then after this there is a deep sleep, what we also call delta sleep, and then REM sleep. REM sleep is also known as a dream sleep. Fine. So during delta sleep, very important sleep for your bodily function, normalizing the bodily function, specifically the hormone. Fine, here you can see that specifically the growth hormone is mentioned, because the growth hormone is a such hormone which is secreted during only night hours, and that too in the stage 3 of the sleep, not other stages. Fine. REM sleep is a stage where there is a consolidation of memory occurs. If suppose I'm delivering this talk right now and anybody of you is not going to have the complete REM during night hours, or a little bit of REM during night hours, then that person will definitely have some sort of the missing information when he try to recollect my talk after 1 week or 2, because REM sleep is very, very important for memory. Fine. Now this is the outline how much on an average a person should sleep during his lifetime. So here you can see, observe that newborn usually sleep for 12 to 18 hours. A child of 1-year-old may sleep for 14 to 15 hours. And 1 to 3 years old child is sleeping for 12 to 14 hours. And 5 years old child requires sleep of 11 to 13 hours. And I'll just like to emphasize that this is not the only numbers or figures, you know. These are the hours which are very, very important for your coming future life of that particular child. You know, a child who is sleeping less than 12 hours when required to sleep at least 18 hours during newborn period, fine, may develop some or other sort of the mental illnesses or physical illnesses during adulthood. So it's very, because you may be knowing that, or it is really surprising to know that 90% of the brain development, 90% of the neuronal development, brain development occurs within 5 years of our life. So the 5 years of your life is very, very crucial. No. So nowadays what happens that due to there's a lot of social media, WhatsApp, Facebook, parents do also, they sleep in the late hours, so that their children or newborns also are not sleeping. So this may affect future generation also. The good part recently the government has done is that they have extended the school timing of newborn, the preschool children's, no? The KG's children, now usually the timing was in morning hours. Now they have made it for 9 to, the school are going to start for the preschool children after 9. So there has been a research conducted in the United States also, just extending the 1 hour of school timing, morning or timing, the children are getting enough time to sleep, and their academic performance was very much improved just by extending the 1 hour of the school timing. I mean, early morning schools are not recommended basically for the preschool children. Now, these are the various waveforms by observing which we can diagnose which part of the stage the person is passing through. This is quite detailed for your uh, because for this discussion we require a lot of a short of workshop, full whole day workshop. But still, I would like to tell you that this is what a delta wave, and this is what a spindles. You can see these are the spindles. These are spindles. This is a cave complex which represent the stage 2 of the sleep, and these are the theta waves representing the wakefulness. These are representing usually stage 2, and this alpha waves. You can see these alpha waves. These alpha waves are observed during the relaxation. Fine. And above the topmost one is what a wakefulness, alert waves. Now here at down you can see REM sleep. These are just like a wakefulness wave. So these are the waves which is observed during the REM sleep. Now, as I told you that we follow the cycle of sleep, REM, non-REM, REM, non-REM. As the time passes from your sleeping to morning hours, late night to morning hours, the duration of REM, the red bar here is representing the REM duration. Okay. So this is what 1, 2, 3, 4 stage of sleep. Nowadays we call stage 3 and stage 4 combined N3 only. So as the time passes, before 2 o'clock, first cycle, the REM is having lesser duration, maybe 20 minutes. But during morning hours, you can see 5 to 6. So the REM timing, for example, the total sleep cycle time is 90 minutes. So in before 2 o'clock, REM may be 20 and non-REM is 70. But after 4 o'clock or at the 5 o'clock or in morning hours, the REM may be 40 and non-REM may be 50. So total 90 minutes. So duration of the REM sleep is much more in morning hour. Why I'm emphasizing this part? Because you might have heard in your routine practice that most of the cardiovascular events, specifically, what can say, heart attacks, they do occur in morning hours, early morning hours. The reason is that REM sleep, because REM sleep is a arrhythmogenic sleep. I told you that REM is a total different state of being. The physiological is totally distinct stage. In subsequent slide, I'll tell you how it is different. So mostly because of the REM sleep apneas or some disturbance in the heart during REM sleep, there are chances of developing heart attacks. Fine. And another part there during REM, a normal healthy individual, REM is usually REM is what we describe associated with the brain development and memory consolidation. Fine. So a person who is not sleeping till 6 o'clock in morning hours may have poor quality of REM, means REM duration is less, and may suffer from the your what I can say memory disorders. So it is recommended that now it is usual practice in your society that the individuals those who are appearing for the exams, they get up in the early morning or 4 o'clock and 3 o'clock, or they will remain wake up till night 2 o'clock they are studying. So this is definitely going to alter the REM sleep pattern, and they may not get success what they want. Basically, they are compromising the memory part of their life, that is a REM sleep. So it is advisable that for good academic performances, we should have the sound sleep, that is quality sleep of from night 10 to morning 6. Now, that is during 4 to 6, the REM duration is very much high. So there is a good memory consolidation, and it may be reflected in your academic performance also. Then I would like to skip this due to constraint of time. Now here you can see that as the age advances, from this your life cycle neonates to the old age, you can see this pink part. You know, in children, in neonates, the pink part is very much high. That means this pink part represents the REM phase of your life. You know, so REM phase of your life is much high during the infancy or your childhood, because this phase is required for your brain development. As you grow older and older, you find that the REM duration is going less, becoming less. Fine. So increase in the REM duration is correlated with your old age also. So if suppose if you could maintain proper sleep hygiene, sleep protocol, sleep balance, then the aging phenomena could be slowed down. You know, if you are having good quality sleep plus duration which is required for your own age, then you may not, or you may less suffer from aging disorders. Now, this is how I wanted to tell you that the REM and non-REM, how they are different phases of your life. Fine. In REM, you can see the heart rate is regular. Sorry, in non-REM, that is, your heart rate is regular, your respiratory rate is regular, blood pressure is regular, skeletal muscle tone is also preserved, you know, and brain oxygen consumption is reduced in non-REM, ventilatory response is normal in non-REM, temperature is normal, and sexual changes are rarely occur during non-REM sleep. During REM, you can see that whenever REM sleep is there, your heart is irregular. That means the brain is not having control over your heart rates or heart functioning. That's why any person who is having blood pressure or some coronary artery disease or dyslipidemia, they do have some heart issues, but brain is not having full control over the heart rate. So during this REM phase, the heart is having irregular activity, so is more prone to develop arrhythmias, ventricular fibrillations, or some atrial fibrillations, and may result into cardiac problem or cardiac arrest. So that's why in morning once you do get the card. Similarly, respiratory is also irregular. The supply of oxygen is also then irregular. Blood pressure is not constant. Total autonomic nervous system, which is under direct control of the brain, is not been synchronized. It is functioning on its own. Another important aspect how the REM is differing from the non-REM is what? Skeletal muscle tone. You can see here the tone is absolutely zero. There is no tone during the REM phase. That means muscle are totally like a dead body. You know. So this is very important finding in the REM sleep. Brain oxygen consumption is increased. As increased, you know, that the even their research, it shows that the temperature of the brain tissue itself is very high during this phase, because there is a lot of metabolic activity going on during REM sleep. So what I want to emphasize here that normally our societal concept is what? That sleeping means what? Wastage of time, you know. जो ज्यादा सो रहा है, it's waste of time. But sleeping is having tremendous importance in your life. You can see here during REM, ना हमारा brain daytime में काम नहीं करता, उससे ज्यादा much more than that it works during the night hours, during REM sleep. Okay. And another important finding which has been noted during the REM is what? Temperature of your body is biokilothermic. What does it mean? Normally, our body temperature is regulated. That means even if I go to the cold place, my temperature will be 98 degree Fahrenheit. If I go to the hot places, my temperature will be 90 degree Fahrenheit. Fine. This is why it is happening. So it's constant because of there is a thermoregulation mechanism in your brain. But during REM sleep, this thermoregulation mechanism is also been shut down. The temperature regulation occurs as per the atmospheric temperature. If you are sleeping in the cold environment, your temperature will be relatively cold according to the environment. If you are sleeping in the hot environment, your body temperature will be hot according to the surrounding environment. Fine. This happens only during the REM sleep. So most of the important functions also are being shut down during REM sleep. Only thing is you observe is that there is a rapid eye movement. That's why it's called as a REM sleep. Rapid eye movement. There's a constant biphasic movement of your eyes during the REM sleep. And the important function which has been performed during REM sleep is what? Brain tissue rejuvenation and memory consolidation. Now I need not go to details of this. I would like to just mention a few things here. Sleep influences major physiological systems of your body. Thermoregulation is done by during sleep. Endocrine system, growth hormone, melatonin hormone, very, very important hormones. They are being secreted during night hours only. Melatonin hormone, need to mention one statement regarding this. Melatonin is that melatonin is a master hormone, what they call it, and it is having a lot of important properties like it is strongest antioxidant in your body. And another thing is that it's oncoprotective. This hormone is oncoprotective, means to what? It prevents an individual from developing the cancers, malignancies. We did one research at our place itself, and we found that most of our lung cancer patients were having poor sleep hygiene, poor quality of sleep since almost more than 10 years, and they land into the development of cancer. So this hormone is very, very important hormone, and this hormone is usually secreted during only night time. Now, these are the various other hormones which are very important during sleep. I mean, they're secreted during only sleep. Then one thing again I would like to mention here, ghrelin and energy balance hormones like ghrelin, leptin, and your insulin. These are the energy balance hormones. Ghrelin is a hormone which stimulates hunger. Leptin is a hormone which gives you satiety after eating. If suppose there is imbalance of this hormone, a person is going on eating, may not feel satiety, so there will be increase in weight and there will be insulin resistance. So all this would lead to a lot of complications, what we call the metabolic syndrome sort of thing. Fine. I told you regarding all these things. Obesity, immune system. So there was an experiment conducted on the rats. They totally deprived the rats of sleep, and they found that the rats die within 2 to 3 weeks of the deprivation. So it means that sleep is very, very essential because other things were properly fed to the rats. When food was given, water was given, but the rats were deprived of sleep by constantly stimulating their brain during night hours. So all the rats died within 2 to 3 weeks. So you can see the importance of how much sleep is important for your life. Another thing is that some rats, they did another experiment that they deprive the rats of REM sleep, and they allowed, but the moment rat was landing into the REM sleep by monitoring on the EEG, they used to stimulate it, so the rat was not entering the REM sleep, and they were allowed to have non-REM sleep. So this rat also died about 6 weeks, you know. So REM sleep is also equally important for your life. So sleep we need for life. Now this was what the basic fundamental of sleep, which I told you in brief. Now coming to in brief, I would like to tell some disorders of the sleep, how important it is, and how to manage those disorders, what are the tests which are used to diagnose the various sleep disorders. The sleep disorder has been classified broadly into the insomnia disorder, hypersomnolence. Insomnia means the person who is having delayed onset of sleep. That means he's going to the bed and he's not getting sleep more than after more than 30 minutes, then we label the person as having insomnia. Hypersomnolence disorder means that person may be feeling sleepy during daytime hours, while driving or while reading the textbooks, or even most of the participant in this talk may be sleeping. If you are listening to the talk, also promote the sleep. This talk sort of the disorder, we call it as a hypersomnolence disorder. Then narcolepsy, I told you that there is a hypocretin substance which is lacking in your brain. Result in narcolepsy, the person is going to sleep for a longer duration and hardly wakes up for the routine activities. Then there are breathing related sleep disorders, then circadian rhythm sleep-wake disorders, non-REM sleep also disorders. Means there are disorders related to the particular stage of sleep also, phase of the sleep also, right? Non-REM disorders are different and REM disorders are different. Okay. Then restless leg syndrome is another very common disorder which has been misdiagnosed or underdiagnosed. And there are some substances which may cause some sleep disorders. Fine. some drugs also can cause some sleep disorders. So there are almost more than 88 types of sleep disorders classified, given by International Classification of Sleep Disorder. More than 88 types of disorders, You take any system like renal system, cardiovascular system, or respiratory system, you'll find hardly 20, 30, 40 disorders. But in sleep, there are more than 88, almost now, this time maybe 100, you can consider 100 disorders are there with a sleep. Now, this is what the broad classification of sleep disorders. Now, just to enumerate, what are the intrinsic sleep disorders? Psychophysiological insomnia. Mid-time, what happens, the person may be sleeping, but he may feel that he's not sleeping. That's what we call sleep state misconception or misperception. Idiopathic insomnia, narcolepsy, hypersomnia means excessive daytime sleepiness. There is a post-traumatic hypersomnia. There is a idiopathic hypersomnia. Very, very common, eight number, you can see that obstructive sleep apnea syndrome is very common. Those who are individuals who are snoring, usually almost 99% of the individuals, those who are snoring, do suffer from obstructive sleep apnea syndrome. Okay. Then there is a disorder, what we call central alveolar hypoventilation syndrome, mostly in the obese patient. This is another common disorder, 11 and 12, restless leg syndrome and periodic limb movement disorder. This group of the individual do complaint of uneasiness in the limbs, specifically the lower limbs, while going to the bed. And when they compress the limbs or when they rub the limbs, they feel better and the sleep is induced. So these are the complaints mostly, but most of the individuals, they may feel that these complaints are due to what? Their day-to-day activities or tiredness, something like that. And they may not relate it to the disease, or they may not even come for consultation. But the moment they come for consultation, at that time, they might have developed the diseases higher than this, like individuals, those who are having restless leg syndrome, frequently develop the poor quality of sleep, and poor quality of sleep will lead to other symptoms like daytime sleepiness and some accidents and all, blood pressure, mental disorders and all. So complications of these syndromes, when developed, then the patient come to us. And when we retrospectively examine the patient, that whether the patient were having these complaints, then we found that he was suffering from the restless syndrome. And usually this happens in the individuals, those who are having low level of storage iron in your body. Storage iron in your body. Fine. Now, there are a lot of disorders. You might have heard of it, like parasomnias. Parasomnias means disorders which should not what do you say, affect the quality of sleep, but it occurs when any physical events or experience, which occurs during entry into sleep, means at the beginning of sleep, or within the sleep, or during arousal from the sleep. Any sort of event. Those events we call it as a parasomnias. For example, physical arousal means person has started sleep and is getting awake immediately after 1 hour and getting having confused. So this is a confusional disorder. During this period only, patient may start walking. You might have heard of this. Specifically happens in the adolescents and children. Sleepwalking, sleep talking, sleep terrors. These are all arousal disorders. Then REM behavioral disorders means these disorders are occurring in the during phase of REM stage. So during this phase, I told you that REM is to be remembered for two things. First is what brain memory consolidation, brain tissue rejuvenation, and third is dreams. Dreams usually occur during this stage. So if suppose person experience nightmares and he due to this nightmares, sleep get disturbed or interrupted, then it is again disorder. Then during REM sleep, what happens if suppose normally there should be, I told you that there should be atonia, complete loss of muscle tone during REM. But if suppose person is having some disorder, then there will be no loss of muscle tone. So whatever he is observing in the dream, he may enact during the sleep and may injure himself or others also, sleeping partner also. And any individual, those who are suffering from this REM sleep behavior disorder, they do suffer in future with Alzheimer, dementia, and Parkinson's. Okay. And these sort of the disorders, parasomnias usually do not require the specialized test like polysomnography. But sometimes if you are confused, if you are not able to diagnose it, we may indicate the polysomnography test for these of the individuals. So again, this classification. Now coming to the polysomnography, how you are going to diagnose, how you are going to diagnose the polysomnography and sleep disorders. So as you know that for cardiac diseases, we use diagnostic modalities like ECG, we use 2D echography, we use angiography. So these are the diagnostic modality for the cardiac disorders. For neurological disorder, we are having diagnostic modalities like CT scan, MRI. So in same fashion, for sleep disorder, we are having diagnostic modality, what we call polysomnography. Poly means multiple, somno means sleep, graphy means measurement. Fine. The individual who is specialized in the sleep medicine, nowadays we are calling it as a separate discipline of the medical science, which has come up now, is we call it somnologist. And there are very few centers in India as well as abroad. We are having centers, but in India, there are few centers where we do train the sleep physician or the physicians who are interested in the sleep. Fortunately, at our center, we have started the fellowship program, which is approved by the university. This is one of the first kind of fellowship program in India, which is for 1 year duration for this. And we are having all these gazettes of this measurement or diagnosis of the sleep disorders. So polysomnography is what a device or equipment which diagnoses the sleep disorders. Now, this is what assembly. Poly is multiple. So we are recording the multiple parameters, like we are recording your heart rate, your respiratory rate, your temperature, your brain activity, your muscle tone. No, so all these parameters are simultaneously recorded. And this simultaneous records then interpreted after recording, at least recording of 6 hours we require, because 90 minutes each cycle. So at least we require 4 cycles to interpret the person is having sleep disorder or not. So 6-hour recording is recommended for the interpretation of the polysomnography. Fine. Now this is what a level 1 polysomnography call it. Level 1 means what? It is a higher end. Means we are putting all the EEG channels around the brain, all the EEG channels, and it is being performed in the laboratory, that is sleep lab, what we call it. So it's a level. It is required when we are diagnosing the rare sort of disorder, sleep disorders, or the patients who are uncomfortable at home. And these are the level 2 and 3 channels. Here you can see this picture showing what EEG recording.
Sorry for the interruption. There was some technical problem. Sushant sir will join again soon. Due to some technical error, his line got disconnected, so he will be joining soon. Just bear with us. Until sir
May I
joins
ask Dr.
again.
Hemant Kanchade sir to help the sir to reconnect?
Sir, he had called me. His line got some disrupted, so he said he will be joining in 2 minutes again. He will get
Okay,
the
fine.
connection and he will be joining in 2 minutes. So till then, I will request all the participants, if they have any questions, they can put it in the chat box.
Very interesting topic is going on, and I suppose all other peoples or all other Rohingya should join it. If not, a message must be circulated to them.
Yes, sir.
Hello. 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 Can you hear me? Hello.
Yes, sir.
Yes, sir.
Yeah, fine. Sorry that there was a disconnection with the electricity. So,
No, no.
yeah, we are having time for, I think, only 10 minutes, no? Yeah.
Sir, you
Sir,
can
not a
continue.
question,
Sir,
sir. We
you
can
can
proceed.
continue. There is no time constraint for you.
Okay, fine. Then
Yes,
it's
sir.
fine. Then it's fine. Okay. So, this is what our level studies. No, just let me make it slideshow. So the diagram on the right side, where the EG channel, sorry, left side, where the EG channel you can see, this is what we call the level 2 study. So here we are getting the EG recording also. And this is what you don't find any EG recording. Here only flow channel is there, then belts are applied, then pulse oximeter is there. This is what a level 3. This is just used for diagnosis of the obstructive sleep apnea. But being a sleep physician, I usually do not go for this unless until we have EEG recording. There is no point in performing the sleep studies because, hello. Yeah. So because if you want to diagnose the REM behavioral disorders, then we will not be able to diagnose during this stage. Fine. With these devices, because this is a level 3 study. Here there is no EEG recording. Here you can have the partial EEG recording, but for detailed recording of the brain EEG pattern, we need to go for the level 1 studies. Fine. Now what we are recording basically in the schematic presentation now. So this we are recording the electroencephalogram. Here you can see electromyogram. Myogram means what? You can see here there is one electrode on the chin itself, So this is going to record the muscle activity. Muscle activity is very important to know whether the person is having atonia or not. Here you can see electromyogram, which measures the muscle activity. When person is awake, muscle activity is there. This is the awake waves, you can see, fine. So otherwise, in sleep or REM sleep, there is the atonia. In REM sleep, there's a complete atonia. There is no tone at all. And this is the nasal airflow recording. Here you can see this is the breathing pattern. Okay, inhalation, exhalation, inhalation, exhalation, inhalation, exhalation. There's a no breath at all. This is what we call apnea. Means for 10 seconds and more than 10 seconds, a person is not breathing, then we are saying it is a apnea. Fine. Again, after apnea, the breath is regained. So person is taking deep inhalation. After breath hold, usually we take a deep inhalation. This is the normal tendency. Then this is exhalation, inhalation goes on. These are the abdominal and thoracic movement, chest movement, you know. So when there is a apnea, you can see these are the thoracic movement and these are abdominal movement. In apnea, the abdominal movements are in opposite direction. Okay, otherwise, normally they are in the same direction. See, thoracic movement are same direction, inhalation, exhalation, inhalation, exhalation. The moment there is apnea, the abdominal movements are in opposite direction. So this is how we are going to diagnose the apneas also. And at the simultaneously, we are recording what? Oxygen levels. Okay, 100% saturation. Then during apnea, there's a fall in saturation. So saturation may go to 50% less than that. During apnea, there is a in EEG recording, you can see as there is a less oxygen supply, there will be a decrease in the heart rate. Fine. So you can see bradycardia in apnea. Fine. These all things we are recording simultaneously in a polysomnograph. Now, apnea, hypopnea. Apnea index is one of the components, figures, or we can say numbers on which we can diagnose the person is having obstructive apnea of what severity grade. You know, apnea means cessation of breath for 10 seconds or more than that. You just see this. This is apnea, cessation of breath for more than 10 seconds or 10 seconds and accompanied by fall in oxygen saturation. Okay, this is what we call apnea. Fine. And this apnea, if suppose they are occurring in 1 hour less than 5 episodes are there, then we say it is a normal. If suppose such apneic episodes are apnea and hypopnea, they combine. Hypopnea means there will be a decrease in flow, but not complete stoppage of the breath, but usually accompanied by decrease in saturation. That's why it is measured combined, because apnea and apnea having hypopnea having same physiological implication. So they are usually measured in combined. So if suppose the events are 5 to 15, then we call person is having mild apnea. If suppose events are somewhere 15 to 30, then moderate apnea, and more than 30, we say the patients are having severe apnea. Fine. Now, whenever there is a apnea, another thing I'll tell you. See, here, this is apneic phase. When there is apnea, the signals are going to the brain that there is no oxygen, so brain goes into arousal. This is arousal. Apnea is usually followed by arousal. See, EEG activities of arousal and muscle tone is also showing arousal pattern. And this is accompanied by the moment there is arousal, the saturation which was fall will start get regaining. Fine. And even in after arousal, there will be a normalization of your heart rate. Fine. So sometimes arousals are very important to assess the quality of sleep. There are frequent arousal, then we say person is having poor quality. So apnea, hypopnea index is interpreted along with the respiratory effort related arousals. Another event is added to that. Okay. So apnea, hypopnea plus respiratory related effort related arousal, then per sleep hours. Okay. So these are counted, same, the categorization is same as 5 to 15, 15 to 30 and more than 30. Now this is a real this picture of your polysomnograph. It looks like this only. In black upper, you can see this waves, different waves. You know, so this is what frontal and mastoid electrode we have applied, and this is the wave pattern recorded. Black one, fine. So this black one wave pattern till here it was appears to be normal. Okay, and then here it has become disturbed. You can see, fine. Means this is what arousal we can say. Again, then it has become normal. Again, here is arousal this side. Then blue wave patterns. Okay, blue wave pattern. They are representing what? Right eye movement and left eye movement. Okay, E1, E2. E is standing for right eye. E2 stands for left eye. M2 mastoid. M1 mastoid. So this blue pattern is representing what? Eye movements. Here you can see arousal movements. Eye movements are also showing arousal. Then this is black one again representing a tone of the muscle. You know, so here during arousal, there is a lot of darkness, blackness is here. Okay, so this is arousal. Then the red is representing EEG pattern. Fine. Then this black one is representing your snoring pattern. Fine. And these waves, chest and abdomen, they are representing the abdominal wall movement and chest wall movement. Down one is the abdominal wall movement and upper one is the chest wall movement. Here you can see. Fine. Now, this is a nasal pressure blue one. It represents the airflow, flow of the air. Fine. Now here you can find that there is a apnea. This period, you know, the pink one is apnea, which is followed by arousal. Fine. The saturation here you can see, this is a normal saturation here, 90%. Okay. And this is 66% saturation. Okay. So this is what we are recording entire episode throughout the night. And then we give the diagnosis of obstructive sleep apnea the patient is suffering from. Okay. So I told you regarding this type of sleeps, there's devices. Lab 1, type 1 is a lab, and type 2, type 3 portable devices. Okay. Now, what are the indications for polysomnography? When to advise polysomnography? So polysomnography is advised if any patient who is suffering from the respiratory sleep disorder. For example, some patient may come to you, he may complain that डॉक्टर साहब रात को मुझे एकदम सांस रुक जाती है, गला चौक हो जाता है, हड़बड़ा के उठ जाता हूँ. फैमिली वाले बोलते हैं कि सांस ही नहीं ले रहे थे आप खराटे बहुत लेते हो, बीच में सांस बंद हो जाती है. All these episodes, if suppose the person is telling you, then person may be having some related respiratory sleep related disorder. Fine. And since there is a sleep disturbance during night hour, because of this respiratory disorder, sleep related disorder, the person may have, whenever the persons come to us, no, they come in the late stages because there is a hardly any awareness regarding this sleep disorders. So I must thank this our team, Rog Nidan Vikruti Vigyan PG Association, for organizing this talk for the purpose of knowledge as well as creating the awareness. No, due to this sleep disorder, the patient develops diabetes, myocardial infarction, ISD, then psychiatric illnesses. So many disorders do suffer, and then patient goes to the respective specialist, you know. And when they do not get treated or they do not get relief at their this allopathic specialist, they will move toward the Ayurveda, they move toward the homeopath. So many special they will move on. But basic root cause is there in a sleep pattern. Okay, and nobody, not a physicians also take care of that. You know, I have seen I have some confront physicians many times. So they do require, they do take history, and they do mention mention sleep pattern or sleep behavior. They do take history in their entire record related to sleep. But in modern medicine practitioners, we see lack of this because sleep has not been given that much importance. Am I audible? Again, there was some this light electricity issues.
Yes, sir, you are audible.
So
loud
you're
and clear.
audible.
Okay, fine. So, so sleep is having a very important aspect in the management of any patient, specifically in the ICUs also. You know, there is a practice in ICU routinely that during night hours, the patients are being given injections, and most of the investigations are being done during night hours. You know, they do not allow the patient to sleep during night hours. And even in bed makings and all, you know, ICUs, morning 6 o'clock or 5 o'clock, that night staffs come before leaving the job, giving handover and go for the bed making, everything. So again, it disturbs the sleep. And night times they are administering the medications also, you know. So now they have come up with the protocols that ICUs should preferably avoid disturbing the sleep in night hours. And the design now, another addition to the ICU designs, now the ICU design should be such that there should be a exposure to the sunlight, you know, so that day-night cycle can be recognized by the patient. Usually what happens during in ICU, the patient do not know, even doctors do not know whether it's the day or night. The resident doctors, those who are working for almost 12 to 18 hours, no, they do sleep there itself. JR1 at our places also, they do not know whether it's the day or night. So ICU should be designed that fashion because we are functioning in accordance with the, what you can say, in tune with the nature. That is light and dark cycle. So any patient, those who are suffering from any sleep disorder, whether it is a respiratory sleep disorder, whether it is a movement and behavioral sleep disorder, non-respiratory disorder of the hypersomnia, मतलब daytime sleepiness है, insomnia and other insufficient disorder, sleep disorders, all these patients will present the main presenting complaint of sleep related disorder, like patient will complain of hypersomnia or patient may complain that he is not getting sleep. But another complaints would be related to the complication of these disorders, like if suppose patient develop hypertension, patient develop diabetes, patient develop COPD, patient develop pulmonary hypertension, patient develop hypothyroidism, they may complain of all. So my intention of telling all these things is whatever may be the complaint, presenting complaint, you should take history related to sleep complaints, because these disorders are a complication of the basic sleep disorders. Okay. Now we'll have one case that is, and just see. Now this is a 47-year female, okay, with a history of depression. Fine. So psychiatric illness, depression, anxiety. History noted for childhood trauma. She had a childhood trauma. Okay. Then subsequent spousal abuse also, and alcohol abuse also. Then there is a history of chronic fibromyalgia. Okay. This is a chronic fibromyalgia is a sort of disease, what we call connective tissue disorder, just like in Ayurveda, what we call Vata, So it's a type of Vata. So referred by the pain specialist for snoring. Okay. And for OSA evaluation, whether the patient is having, a female is having obstructive sleep apnea syndrome or not. Fine. So I'll tell you, chronic fibromyalgia is a condition which cannot be diagnosed exclusively on the basis of symptoms or any other blood investigation. I'll tell you, it is diagnosed on the basis of polysomnography, because this group of the patient in polysomnography, they show alpha delta pattern. Alpha delta pattern means wakefulness waves and delta means deep sleep waves. They are alternating throughout the polysonogram, and this way we are diagnosing the chronic fibromyalgia. If you are not advising such group of the patient the polysomnography, you will never diagnose the patient as having fibromyalgia, and you will just go on treating like any other disorders. Okay. So history of sleep initiation and sleep maintenance insomnia. This lady was having another point, that she could not initiate the sleep. And if sleep was initiated, then she could not maintain it. There was frequent arousal. Fine. There was an uncomfortable sensation in the legs. Fine. She had nightmares also. She had a teeth clenching also. Frequent nocturnal awakening also. And in morning, non-restorative sleep. What do you mean by non-restorative? This is another very important complaint. If you ask patient or person, is complaining that डॉक्टर साहब मुझे मॉर्निंग में उठने के बाद में बिल्कुल फ्रेश नहीं लगता, ऐसा लगता थोड़ा 15-20 मिनट और सो लिया जाए. ठीक है. If suppose this statement occurs, then that individual is definitely suffering from sleep disorder. It could be anything. It could be REM behavioral disorder, it could be arousal disorder, it could be apnea, what it may be. But these are the symptoms. So this is another symptom which is very important to ask, non-restorative sleep. Okay. Then wake up from tired. Means when she wake up, she get tired. Severe daytime sleepiness. Cataplexy, sleep paralysis. What does this mean? Cataplexy, sleep paralysis. Cataplexy means what? There is a sudden loss of tone. I told you that in REM sleep, there is a complete loss of tone, If suppose such lot of loss of tone is occurring during daytime also. If suppose this usually happens in the individual, those who are having irregular sleep patterns, especially the adolescents, they sleep at a very late night and get up during late hours, and they are stressed out because of the studies or work, whatever it may be. So these individuals may have some emotional disturbance, they are emotionally labile. And if suppose some emotional activity is happening, whether in his life or her life, or even like watching movies or television, some emotional episode is there. So they may have complete loss of tone, and they may fell down on the ground or fell down on the couch, and may feel, but they are conscious. But mentally, I mean, they are able to recognize everything during that period. Something is happening, everything around surrounding, they are also recognizing it, but they are not able to move. There is a loss of consciousness, loss of muscle tone, not consciousness, loss of muscle tone. So this is what is cataplexy. Similarly, cataplexy can occur at the beginning of the sleep, or it can occur at daytime also, if suppose there is any strong stimulus. And sleep paralysis. Sleep paralysis usually occurs during initiation of the sleep. Means the moment one goes for the bed, there is a complete loss of tone. Usually loss of tone should occur during REM sleep. But if suppose it occurs at, we call it as a sleep paralysis. So clinical evaluation, everything has been taken. We have taken the history of sleep wakefulness history, ENT, then post-traumatic stress disorder scale and everything, sleep diary, and polysomnography, and maintenance of sleep latency test. These are the various tests. So related to polysomnography. So the diagnosis, what patient was having OSA, okay, obstructive sleep apnea syndrome. Patient was having restless leg syndrome because the complaint were what? Uneasiness or in the leg, uncomfortable sensation in the leg, you can see here. Fine. Chronic insomnia, not able to initiate the sleep and maintain the sleep. And bruxism, there was clenching and narcolepsy. Narcolepsy because patient was having cataplexy and sleep paralysis at the initiation of sleep. Okay. So whenever a patient just goes for the sleep and there is a complete paralysis of the body, is just breathing, not able to move it, then we say the person is having 90% cases, the person is having narcolepsy. Fine. So this is what the polysomnograph of the same individual. Okay. I'll not go into the detail of that. So a few words for this apnea, then we would like to end it here. Fine. Apnea is very common sleep disorder. Okay. There was a survey conducted in the United States. All the patients were having symptoms suggestive of the sleep apnea, but 61% of the patient, the individuals, they refused that they were having any sleep disorder associated with apnea. And I'll tell you regarding this one. What happened during the apnea pattern? Normally, a person is breathing during sleep, it's normal. During sleep, air can travel freely into the air from lungs to your airways. Free breathing. Okay. But in apneic individual, you know what happens during sleep? There is a collapse of the soft palate, tongue fall down on the pharyngeal wall and epiglottis also. So this passage has been closed. Okay. So there is a no airflow. No airflow. If this no airflow lasts for 10 seconds, then whatever the amount of the oxygen was there in the previous breath, that is being utilized for another 11 seconds. 11th second, we need to have new oxygen. So new breath. But since there is an obstruction, breath is not going in, and oxygen level or saturation has been fallen down, so the brain will get wake. Okay, and then it will restore to normal. So this is what we call apnea, obstructive sleep apnea. Okay, sleep apnea is a potentially dangerous medical disorder where breathing stops during sleep for 10 seconds or more, along with falling oxygen level below 94. I do have seen the patient who has fallen oxygen saturation falling down to 29% of this. So if suppose this happens during your daytime or in ICU, even nighttime also, we would have intubated that patient. Fine. So it's that dangerous, obstructive sleep apnea. What happens? Keep on decrease in muscle tone, apnea sets in. There is a hypoxia, means oxygen level goes down, carbon dioxide increases. Then there is a lot of efforts in breathing. Increase effort of breathing leads to arousal. That arousal means for disturbances in sleep. If suppose disturbance in sleep is occurring, then all the function of the sleep, which has to be done by during sleep, is also hampered, and which leads to the various disorders. Then there is arousal, there is a relief of obstruction. Then again, breathing is normal, resume sleep. Again, same cycle goes on. This is what we call apnea cycle. I have already told about this apnea cycle, mild, moderate, and severe grade. Fine. So what happened during this apnea cycles? No, apnea when there are apneas. So all these apneas and arousal. See, there is a fall in oxygen saturation, one feature of the apnea. There is arousal, there is another feature of apnea, and there is a increased respiratory effort or increased thoracic pressure. All these things leads to what? Physiological alteration in your body. And those physiological alteration are what? Sympathetic activation, endothelial dysfunction, hypercoagulability, inflammation, oxidative stress, then metabolic dysregulation, and all these physiological alterations leads to hypertension, arrhythmia, sudden death, myocardial infarction, brain stroke, heart failure. So whenever you get patient of and cardiac illness, not only this is, I've just shown the cardiovascular part, but this alteration in your body because of this apnea or sleep disturbances can lead to any sort of disease. Okay. So always be alert to find out that whether the patient is suffering from any underlying sleep disorder also. Okay. Now, what are the symptoms of sleep apnea? I told you, sleep disturbances, concentration, memory problem would be there. Disturbed sleep and excessive daytime sleepiness, morning headaches. Many times, the neurologist sees that patient comes to them for headache, and they do prescribe. They may diagnose it as having migraine. They go for the MRI, CT, everything they go for. Fine. And I do get referral from the neurologist. And when we did the sleep study, we found that the person is having sleep apnea syndrome. No other complaint, only headache, that too morning headache. And specifically at the occipital region, not frontal. It's very specific headache, loud snoring, gasping or choking while sleeping. This is another very dangerous complaint. Many patients do complain of nausea, unknown cause, only nauseating, feeling of nausea, that's all. And another, this very common symptoms I do encounter in my practice is what? Frequent night urination. I have almost every month, 2 or 3 patients I'm getting referred from the urologist. Urologist. They go to the urologist because I told you that whatever the organ is having complaint, it's always tendency to go to that particular organ specialist. So people go to the specialist for urology, baar urine jana padta hai, baar urine jana padta hai. Everything is normal. Fine. Then we go for the sleep study. We find that the person is having sleep apnea. Fine. Severe grade of the sleep apnea. Another important finding is irritability, feeling of depression. Most of the time, depression and irritability, they do diagnose. They means who the concerned psychiatrist or mental health specialist, they diagnose this patient, depression patient or irritable patient as having some psychotic elements. But keep in mind that these symptoms are not always associated with psychiatric element or psychotic elements. These are just because of the disruption in your sleep, disruptions in your sleep or poor quality of sleep. So all these symptoms, though has been mentioned under the head of sleep apnea, they may present with any of the sleep disorders. Fine. Erectile dysfunction, another very, very important complaint. Most of the time we say there could be some endocrinological issues or some anatomical issues. No. Sleep disturbances itself in any form may lead to erectile dysfunction. Specifically, the sleep disorder known as sleep apnea. Fine. Another, a person who is having sleep apnea, her spouse or his spouse may suffer from insomnia because of what? Constant loud snoring during sleep. So both of them will suffer from some sleep manifestations, sleep symptoms, I'll skip this part. These are the various questionnaires to diagnose sleep apnea. And these are the various modalities to treat this sleep apnea. We do advise weight loss, CPAP therapy. CPAP means continuous positive airway pressure therapies with various new gadgets. Then if suppose there are enlarged or tonsils, sinuses, then we go for the for airway surgeries. And now there is another specialty, what we call dental sleep medicine specialty. They do advise some oral appliances for advancement of the mandible so that the apnea intensity would be less. Then implantable neurostimulator. Now we are having some stimulator. This has not come till in India. It's on the experimental phase only. Now these are the various appliances, and this was a sleep app device which has to be used in obstructive sleep apnea treatment syndrome. So this is all about sleep disorder, sleep apnea. And there are a lot of things to tell you, but due to constraint of time, it may take entire day. Circadian sleep disorders, insomnia. So I would like to end it here. Better next time, I would be happy to talk on other sleep disorders in depth. If you feel that I should be called next time in your meetings. Before ending, I would like to just my real case, first real case. When first and two cases I'll just describe to you, and then we will end. When I did my fellowship program from Hopkins in 2007, completed 2007, then I came back to Nagpur, and then I developed a habit of searching sleep disorders in every patient. My basic specialty, primary specialty is pulmonology, but since there was one chapter in pulmonology medicine, that is sleep apnea syndrome, which is respiratory related sleep disorder breathing. So to study this part, we need to go for entire study of neurology and neurobiology and so many things, and depth of the sleep, how the sleep is initiated, promoted, various stage. So then I developed interest in the sleep medicine. So I got selected for the sleep medicine program. At that time, in 2000, it was in 2006 I went there. So they selected only 10 individuals around the globe. From India, myself and one person from the AIIMS Delhi was there. So we did that program at I did that program at one of the best institute in the world, that is Johns Hopkins Medical University. And after learning there, they offered me the position of research assistant over there. But I thought I should go back to my country, and because sleep medicine was at very rudimentary stage at that time. Nobody was interested, and even not knowing or not aware of all these things. So when I came back here, I started my practice of sleep medicine in Nagpur city. And then later on, I organized various international conference of sleep medicine in Nagpur also. So when I completed the program, I came back here. Then whenever I used to get the respiratory patient also, I used to find some sort of the sleep disorder in that patient. So this was the first case which I diagnosed as having sleep disorder. So this was the individual to whom I encountered in September 2008. He was a medical doctor. Weight was 70 kg. Height was 170 centimeter. BMI 24. And he was having a history of URI for 7 days. He came to me for upper respiratory tract infection. The BP was 160 by 100. He was having neutrophilia. And he just observe here, he was also having that hemoglobin of 24 gram. Normally the hemoglobin should not be more than 16. He was having 24 gram. So increased hematocrit. He was having history of smoking for 15 years. He was having alcoholism for 10 years, and a history of snoring, since 10 to 12 years. He was snoring for 10 to 12 years. That means since the age of 25 or 22, he was snoring. And he had a history of road traffic accidents in 2005, just 3 years ago before my encounter. And he was put on mechanical ventilation at that time. We did his pulmonary function test, found that he was having obstructive airway disease. The ABG was normal. We did his 2D echography, which was showing the features of this hypertension, that is concentric LVH. I did CT neck just to rule out tracheal stenosis because the patient was put on mechanical ventilation. I obtained the opinion of hematologist also to assess what is the cause for raised hemoglobin or polycythemia, increased RBCs. But there was no obvious cause given by the hematologist. I did the sleep study, and I'll tell you that at that time, I was just having that level 3 sleep study. I could not record the EEG pattern at all, only saturation, the chest wall movements, and ECG. So I found that he was having 48 episodes of apnea in an hour. Okay, what does it mean? So he was having, I told you that less than 5, mild, normal, 5 to 15, mild, 15 to 30, moderate, more than 30, severe. So severe grade of sleep apnea was suffering from. And the saturation index was every 52 times in an hour, the saturation was falling down for less than 94 for 52 times. Okay. So severe desaturation index. Also, he was having, I kept the diagnosis of what? Because of the PFT showing obstructive airway disease, I kept the diagnosis of chronic obstructive pulmonary disorder, obstructive sleep apnea. I advised him CPAP therapy. Okay. After 6 months, his hemoglobin came down to normal 6 grams per cent. Since then, now also, he is under constant use of CPAP therapy. To see the importance of sleep medicine. Okay. Then last, it's another case, very important case. This patient came from the Raipur. She was an obese female. Weight was 86 kg. Height was 155 centimeter. BMI 36. She was referred for polysomnography and neurology. Okay. And she went to a neurologist for complaint of hypersomnolence. Hypersomnolence means what? Excessive daytime sleep. Well, while sitting, within 5 minutes, she used to sleep. I had a patient of a renowned businessman wife. She used to sleep while preparing this breakfast or lunch on the, she used to fall on that cooking chula, gas chula. Because she was falling on the cooking chula, then they came to us. But at that time, we have created a lot of awareness in this city, so people used to come directly for it. But this was the time when hypersomnolent patient, she went to the neurologist, and neurologist sent me for this sonography. So she was non-diabetic, non-hypertensive. She was having hyperthyroidism. There was a history of hypersomnolence, and she was also having heart issues related to the. These heart issues have developed after sleep disorder. She had a right ventricular, a right atrial dilatation, and moderate amount of pulmonary artery hypertension also. I did sonography at that time. I purchased the polysomnograph machine, and I did that machine was at that time it was costing almost 20 lakh rupees. In 2009, something like that. So polysomnography I did in the hospital, and she was having 6 apneas per hour. Okay. Her desaturation index was 28 per hour. Means saturation was used to fall below 94%, 28 times in an hour. And below 94% means what? It could be anything. It could be 50, 60, 70, or lowest what I observed was 29. This was the patient I was telling you. I observed the saturation lowest till date. My practice of almost 2007 till now, 12, 15 years practice of sleep medicine. I have never seen the person having saturation fallen down to 29. And arousal index. The moment there is apnea, I told you in that particular slide, when there is apnea, cessation of breath means there will be there has to have some arousal. Brain will get awake. Why? Because there is less oxygenation or no oxygen. So apnea index and arousal index are usually parallel. Means if suppose apnea are 36, the arousal index should also be somewhere around 35, 36, 37, whatever it may be. But here you can observe it is just 17. you know. That means all the apneas were not associated with the arousal. It's again quite dangerous. It is again very much dangerous. If there is no arousal, that means there is no there will be a lack of oxygen and organs may land into failure or arrest. Fine. So next day after that PSG, I advise for ABG. Okay. So ABG means arterial blood gases values. For this pH, what we measure the acid level of the body is normal. Oxygen was very low, 9 mmHg. Saturation was 69. In this is daytime ABG. Night you have seen that in polysonography we found that saturation was going to 29%. Daytime he was having saturation 69. And you see the PCO2. You know, PCO2 is carbon dioxide level. Partial pressure of carbon dioxide was 60 mmHg, very high. Normally it should be 35 to 45. High. So her brain, her respiratory center was not able to exhale the carbon dioxide. Her respiratory center is not able to maintain the ventilation, enough ventilation, so that the carbon dioxide level should be normal. What my point? So hypoventilation was there. Not enough ventilation means hypoventilation. So I diagnosed this patient having as a obesity hypoventilation syndrome, and obstructive sleep apnea. Okay. So very next day after the studies and all, we advise CPAP therapy. Very first day of the CPAP therapy, her hypersomnolence of next day vanished, you know, and she had a normal SpO2 very next day. But so again, why I'm telling all these cases, there is a very, very tremendous importance of the sleep medicine. And we need to recognize the various symptoms of the sleep medicine. And we need to very cautious when to advise the studies and when not to advise the studies, and what type of the studies one should advise, because this patient would have never been diagnosed on your level 1 studies. जो घर में करवा लेते हैं हम लोग, जिसमें just belt, we put the belt and put the oxygen saturation. No, this patient required, because I'm going to measure the arousals. You know, see, अगर ये suppose I would have done this tray at the home. You know, आजकल market में you might have seen that most of the company people are coming and sir ये करवा लो, ऐसा हो जाता है, ठीक होता है ऐसा. But उनमें आपको यही मिलेगा. What you will get? You will get just the apnea index. If suppose I would have not got this value, I would have never diagnosed her as having obesity hypertension syndrome, because management of the apnea and obesity hypertension syndrome differs very much. Okay. So there are a lot of cases to discuss, but due to constraint of time, I feel that all of you might be hungry. Also, it's the time for lunch. So I shall end here, and I would like to thank you very much for inviting me as a speaker for this your webinar series on various medical disorders. And these are the take-home message. No. Just before ending, again, I would like to tell you so many things, but due to time constraints, disorders can lead to metabolic disorder, psychiatric disorder, neurological disorder, pain, and cardiovascular disorder. So any sort of disorder, if you get, you need to think about the sleep disorder, basic sleep disorder, and basic underlying disease. Okay. And the take-home message would be that sleep history is very important part of your clinical work. Okay. Polysomnography is important for diagnosing intrinsic sleep disorders. Okay. And if suppose there is a respiratory related breathing disorders, sleep related breathing, respiratory breathing disorders, in that case, the polysomnography is an indispensable tool. You know, without that, we cannot diagnose it. And polysomnography is recommended in a patient, those who are having congestive heart failure, hypertension, pulmonary hypertension, diabetes, insomnia, diabetes specifically uncontrolled, insomnia not controlled with the drug. In fact, I'll tell you that patient those having sleep apneas, no, they do complain that night time they are not able to sleep, and most of the psychiatrists they prescribe them sleeping medication. Ab hota kya, if you are going to give the sleeping medication to these individuals, their apnea level will be increased because the brain will be slow down due to sleeping medication, and apnea level will increase means what? There will be lack of oxygen to other organs, and organ will land into the arrest or failure. So it is very dangerous unless only we diagnose the patient is having apnea or not. Insomniac patient having apnea, don't prescribe the sleeping medications. So insomnia patient need to be diagnosed with a polysomnography. Then diabetes, pulmonary hypertension. I told you that another important aspect that all the patient of hypertension, those who are requiring three or more than three drugs to control the hypertension, what we call in medical terminology that resistant hypertension, resistant blood pressure, resistant hypertension. These individuals need to be, have to be, must be subjected for polysomnography. Okay. So sleep is a sacred, respected. Thank you very much for patience listening. Any questions are there? You can ask me, or you can just email me, or you can text me on the WhatsApp. Thank you very much. Thank you, Pallavi madam, and thank you, Subhash sir, and other office bearer of your organizations. I'm very much grateful and thankful to you for organizing such a wonderful series. Thank you very much.
Thank you so much, sir. That was really amazing, mind-boggling session, and I would say awakening session, because sleep disorders are something that we totally miss in our clinical practices, and it has to be focused as a separate specialty. So we are having a few questions. So we will take those questions. One was, what are the factors which expand the REM time, and do REM is affected by the type of dream?
What, will you please repeat it? Hello?
Yes, sir. So the question is, what are the factors that
Yeah.
will expand the REM time, and is REM affected by the type of dreams?
Yes. So very good question. I told you that REM is a totally different state of your being. Fine. And if you are sleeping for the less time, as according to your age, obviously the REM duration would be less. And there are certain drugs, specifically the psychiatric drugs like antidepressant drugs, amphetamine and all, they do reduce the REM sleep time. Okay. Your question, what I understand, was how to increase the REM sleep time. Till now, as such, there are no effective way to increase the, pharmacological way, not effective way. There is no pharmacological way or drug related way to increase the REM sleep time. If you will have the perfect REM when you are having balance and in tune sleep activity with a dark light cycle. That means if you are sleeping at 9 o'clock and getting up at 6 o'clock, your REM sleep will be wonderful. It will be always have a normal duration or more than normal duration. Fine. So if you are for that, you need to follow the dark light cycle. That is the only way to maintain the sleep pattern. And then next part of the question was what?
So the next question is, do REM is affected by the type of dreams?
Yes. Now, see, I would again suggest this organizer to arrange another talk for the dream part of the sleep. Dream is wonderful topic. There are various types of dreams. And I told you that the REM sleep, there are this dream is this sleep or this stage is also known as the dream state of the sleep. In your ancient text also, we call as a Swapna Avastha. During
Yes, sir.
Swapna Avastha, during Swapna Avastha, sleep, the dreams, usually it depends what has initiated the dreams, For example, there are
Yes, sir.
this is what we are telling Suchak type of dreams, what we call the indicative dreams. There are
Yes, sir.
non-Suchak type of the dreams, non-indicative dreams. If suppose,
Yes,
for
sir.
example, I'm telling you a person who is sleeping quietly, okay, and he during night somebody tickle at his cheek, okay, just like this. So he may dream that he's eating some sort of the sweets or rasgullas like that. The stimulation was from the outside. The brain interpreted in different fashion as if the person is eating rasgullas. If suppose the person moves the blanket rub the blanket over the legs, the person may dream that that he's walking on the snow or something like that. Fine. The stimulus. Another part of this is what these are what the non-individual dream, but the stimulus is from the external side. हम लोग बाहर से stimuli कर रहे हैं. There are internal stimulation. Now the second part of the answer to the second part of the question, internal stimulation. Internal stimulation means what? A person, the stimulus for the dream is coming from the internal organs like bladder. If you are not voiding the bladder, you know, जैसे हमको in our practice, ancient practice, our parent used to tell that normally also that कि सोने के पहले you should go to the toilet and then come back and sleep. Fine. So not voiding the bladder. So bladder is full. So there are internal stimulation, internal impulses are going to the brain. Okay. And this may be interpreted as something very nightmare. Similarly, hearts, you know, heart issues. If suppose your heart is ailing, you know, the person is having dyslipidemia, maybe having cardiovascular ischemia, something like that. So this during dream sleep, what happened? I told you that dream sleep, everything is unstable. Heart beats at its own speed. Okay, so that signals will be going into REM phase of the your stage, and it may be interpreted or it may be visualized as a very different nightmares. Nightmares means बहुत भयानक डरावना सपना आप उठ के ही बैठना है आपने, no? So again, this will
Yes.
cause disturbance in the sleep, dream sleep. Dream sleep disturbances will affect your again brain pattern. So dreams do affect the REM sleep. And nowadays, scientists are working on the dream pattern to interpret, because dream, see, small element is there in the heart. So he may only dream it because the signals are going to the brain and he may have only nightmares. When the large elements are going, he may develop heart attack. So now the scientists are working on the dream assessment or interpretation of the dream pattern and prediction of the various serious illnesses. So dream do affect the REM sleep, and affection of the REM sleep do lead to various serious issues. Hope I have answered the question.
Yes, sir. Yes, sir. And sir, in Ayurveda, sleep has also in lot of chronic disorders, the dreams or bad dreams have been mentioned.
Yeah.
So there are quite other questions also. So I would request you to please share your email address so that
Yeah,
our participants and audience can get back to you
yeah,
if they have
yeah,
any queries. Now,
yeah.
moving forward, I would request our today's chairperson, Dr. Sachin Deva sir, to express his fruitful notation.
A very good afternoon to all. Thank you, madam. Firstly, I want to thank Dr. Sushant Meshram sir for such a wonderful and brainstorming session on this sleep. So many points, so many relevant points regarding sleep has been discussed very well by sir. Many of the things I have noted down, like sir was discussing regarding hypothalamic and the brainstem sleep wave system, human circadian rhythms, the difference between REM and NREM sleeps, sleep cycles, the hormones which are related released during the sleep, then apnea and hypopnea index, indications of PSG, case studies which he has come across. So in general, why these kind of things, this topic is required. I just want to highlight this. Whenever we take the case, we usually come across with this particular point regarding the sleep, and whatever we have seen, like sleep, usually people will tell it is disturbed, and it's a tendency of many of us to just like neglect that part. So ultimately, the person, when it continues, will land up in psychosomatic disorders. So the negligence is there. Currently, there is an awareness going on regarding the sleep, and such webinars will definitely throw a light on the importance of a sleep. So that may be one of the reasons during the Samhita Kala also, during that period also, they have told that Nidra as one of the Trayopastamba along with Ahara and Brahmacharya. So a lot of explanations and the clarity regarding sleep. Yeah, due to time what restrictions, he might not have gone through entire thing, but this was such a wonderful session for us, sir. So hope we will have your sessions in different topics related to different things in future. At last, I just want to tell that first we waste our health in search of wealth, and later, next we waste our wealth in search of health. So thank you very much. Thank you, RVPGA, also for giving an opportunity to be a chairperson of this session. Thank you.
Thank you, Sachin, sir. Thank you very much.
Thank you, sir, for your remarks, sir. Now, for the vote of thanks, I request Dr. Shubha Sandur, Madam, Professor and HOD, Rognidan Vikriti Vigyan Department, Shri Bapu Singh Ayurvedic Medical College, to deliver vote of thanks.
Thank you, ma'am. Thank you, sir. My heartfelt thanks to the guest speaker of the day. We really felt happy by knowing the knowledge about the studies as well as including the clinical experiences. We are really enriched with the knowledge about the sir's clinical as well as teaching experiences, and he has shared flawlessly. We are really conveying our heartfelt thanks. And first of all, my heartfelt thanks to the seminar organizing committee and our president of the RVPG Association, Dr. Subhash Wage sir, and entire team for giving me an opportunity. And then my heartfelt thanks to the chairperson, Dr. Sachin Deva sir, as well. And with a consistent of time also, Dr. Satyendra Singh sir introduced sir in a very well manner. So all the pains and pleasures taken from the entire team to organize this and to make it success, I would like to provide my heartfelt thanks to everyone. And the more major thing is the technical support from the technical team, and moreover the net facility and other things which are got from the latest technology. I would like to give the thanks to every area where we are able to meet across the areas. And thank you one and all.
Thank you so much, ma'am, for doing the honors. I hope to see Dr. Sushant Meshram sir again with a few other topics also. With this, if with the permission of our president and the organizing committee, as today's organizer, I conclude this session. Thank you.
Before conclusion, may I add
sir.
a few words?
Yes, sir. Yes, sir. Sure,
At
sir.
this juncture, when we are concluding our 2 months long web series, and thank you very much for successfully conducting the web series, Dr. Pallavi. But before that, may I express my deepest gratitude towards Sushant Meshram sir for accepting our invitation on one single request and coming on our dais and sharing his valuable knowledge, true treasure of wisdom. And as in Ayurveda, it's also said that the Nidra is the Trayopasama, third pillar of the third. It is the importance of sleep is given as, it is called as the third pillar of the life, along with diet and celibacy. Hope Dr. Sushant sir is also listening to this.
Yeah. It's true. Very, very true. I have gone through and
along as Sushant sir also quoted that he would also like to present on the dreams, and certainly, hopefully, when our series once again we will resume in August and September, because our academic calendar is fixed. We have 2 months webinar series twice in a year, and one national conference and one workshop in a year. Our entire schedule is fixed. We also run 2 courses, DXDT and DAPT. So on dreams also, we will invite the sir to share his wisdom, because the different types of dreams have been mentioned in Ayurveda. What initiates the dream, as sir has rightly pointed out, the Shruta, Kalpita, Prarthita, what is desired, what is experienced, what we experience in day-to-day life, etc. And what are the underlying diseases also. They initiate some kind of dream. For example, in congestive heart failure, patient awakens with the fear of death in the night because of the congestion in the heart, and this difficulty in avoiding urine also. The circulating catecholamines may give various signals to the brain, and accordingly the various dreams may be felt. So this will be the wonderful topic to talk upon and to listen to. So we will definitely invite you, sir, regarding that. And and I thank everyone in my team to arrange this wonderful webinar series and to make it successful also, and all the audience for listening it patiently. And once again, very lot of thanks to Sushant sir, and namaste, bye bye, and I declare this meeting is over now.
Thank you. Thank you very
Thank
much.
you.
Thank you very much. Thank you, Subhash sir. Thank
Thank
you, Shubha madam. Thank you, Pallavi madam. Thank you, Dr. Sachin sir.
Thank you.
Thank you very much.
Thank you, sir.